Good evening, doctors. This is Dr. Kiran from Shield Medical Affairs. I would like to first welcome the audience for logging into this very, very interesting session, I would say. And it is my pleasure and privilege to introduce Dr. Shweta ma'am. Of course, she needs no introduction. She would be covering the topic of something which is not really spoken about a lot. That is age of the oocyte, the female age, and the ovarian reserve tests, and generally talking about poor ovarian reserve. So just a few words about ma'am. Ma'am has done her fellowship in reproductive medicine. Ma'am completed her post-graduation from the prestigious NDRUHS in Andhra Pradesh. Currently, ma'am is the medical director of the Sridevi Fertility Center in Hyderabad. Ma'am has undergone the advanced ART training at Cleveland Clinic in Ohio. Ma'am has a fellowship in reproductive medicine, as I said, from the University of South Alabama, USA. Ma'am also has a ART fellowship at the Center of Reproductive Medicine from Florida. Ma'am has done many presentations at national as well as state level in different forums on various topics. So with this small introduction, I would like to hand over the session to ma'am. Over to you, ma'am.
Thank you, Dr. Kiran. Good evening to all of you. Hope you're all safe in this COVID-19 pandemic. And at the first, I would like to thank Shield and also Dr. Kiran for conducting this webinar. So today we would be talking on a very interesting topic. The female age, ovarian reserve, and also the ovarian reserve test. What are the implications for ART? So I would be discussing on the age-related decline of female fertility, the relationship between ovarian reserve and the ovarian response, the role of markers of ovarian reserve in predicting the ovarian response, and also the correlation of the ovarian reserve markers and the chance of success in IVF. As all of us know, ovaries contain 3 distinct populations of follicles at different stages of development. They are the primordial follicles, early growing follicles, and also the antral follicles. The ovarian reserve is principally composed of this primordial or the resting follicles. The number of primordial follicles is determined during the early fetal life and it declines thereafter. As such, at 16 to 20 weeks in utero, there are around 6 to 7 million oocytes which are present in both ovaries. This gradually decreases to 2 million at birth and 30,000 at puberty. So there are only 400 follicles which will ovulate during women's reproductive years. So we all know this long trajectory of follicular development. It takes around 85 days for the primordial follicles to achieve the pre-ovulatory status. So this phase is usually, it is independent of the hormone regulation. So once the ovulatory cycles are achieved, so there is a follicular phase which spans around 14 days, where there is a recruitment, selection, and dominance of the follicles takes place. So in the recruitment phase, where there are small antral follicles, either because of the endogenous FSH or because of the exogenous FSH, so these antral follicles, they increase in their size. And after they grow to a certain size, these antral follicles, they release estrogen. This estrogen is produced by all the growing follicles, and this estrogen exhibits a negative feedback effect on the hypothalamo-pituitary axis. So there is a decreased FSH secretion from the pituitary. As such, the other cohort of follicles do not receive FSH, and the follicles which have become dominant, the 1 or 2 follicles which have become dominant, they go to the ovulatory stage and they ovulate. So this ovulatory cycle occurs every month in all the women, and it usually cesses with cessation of menstruation. So what happens here is, as the age increases, as the female age increases, there is a decline in the female fertility. So up to the age of 35 years, there is a decrease in the female fertility, but after 35 years of age, there is an accelerated decline in the female fertility. Traditionally, fertile age was considered to end with menopause, but scientific evidence shows that the fertile age usually ends 6 to 7 years before menopause. And there is a transition period, which is there, in which there is ovulation and also menstruation, which may be regular. That is, the woman may ovulate and also menstruate regularly. But the problem here is the oocytes are no more genetically and structurally normal. That is, during this transition phase, we have more number of aneuploid oocytes, which we get. So here is a picture which shows us the correlation between the maternal age and also the fertility rate. So in the left side, what picture you're showing is the correlation between the maternal age and the fertility rate. It is in women who have conceived naturally, in natural conceptions. So as the age increases, the fertility is usually lowered. The fertility rate decreases. So at 35 to 39 years of age, the fertility is decreased by around 30%. And at 40 to 44 years of age, the fertility is lowered by around 50%. Just as there is a decline in the female fertility with increasing age, there is also an increase in the spontaneous miscarriages that take place. So this figure shows the spontaneous miscarriage rate in a natural conception. So in natural conceptions also, when a woman age is between 35 to 39 years of age, so the miscarriage rate is around 20 to 30%. And as the age advances, the miscarriage rate usually increase. And at 40 to 44 years, the miscarriage rates are usually more than 50%. So this is similar when we see in ART pregnancies also. So in ART pregnancies also, the pregnancy rate and also the live birth rate and also the single infant live birth rates, they usually decrease with increasing age. So more number of miscarriages as such we see with increasing age is because of more number of aneuploid embryos that we get, and there are more number of miscarriages. So to summarize, female spontaneous fertility declines with age in a non-linear fashion. The decline is a combination of decreasing fecundity and increasing attitude to miscarriage. Pro-fertility treatments and IVF are useless against this trend despite however technical progress we have made, but at certain age limit, there is a certain age limit beyond which a live birth is extremely rare, and this can be attributed to the non-availability of the genetically and structurally normal oocytes. Then what do we do for these patients? So is there an implication for the ovarian reserve? Do we need to test ovarian reserve for these patients? How important is the ovarian reserve? Yes, ovarian reserve is a measure of the primordial follicle pool. So what we are doing by measuring the ovarian reserve for these patients is we are decreasing the time to pregnancy for these patients, and also we are giving the fertility treatments in a timely manner, so that these patients have pregnancies in a timed manner. So, ovarian reserve is a measure of the primordial follicle pool. It predicts the reproductive lifespan of a woman. If a patient is having a less ovarian reserve, maybe she is a patient with a primary ovarian insufficiency, she may have a less ovarian reserve, or patient with a premature menopause may be having a less ovarian reserve. And also, ovarian reserve helps us to predict the response to ovarian stimulation. So by looking at the ovarian reserve, we can predict whether a patient is going to hyperrespond or whether a patient is going to poorly respond to our ovarian stimulation. So depending on that, we also can predict our stimulation protocol and other reproductive therapy decisions. Ovarian response to stimulation and number of oocytes retrieved is an important predictor of IVF success. So there is a strong association between number of oocytes and also live birth following IVF. So what does an ideal biomarker of ovarian reserve should have? It should have the ability to measure the ovarian follicle number and also the oocyte quality. It should reflect the functional capacity of the ovary. It should require a minimum number of measurements, that is, it should be more stable with few restrictions on timing of the sample, and it must be more reliable. So do we have an ideal ovarian reserve marker? So the ideal ovarian reserve marker should be accurate. That is, whenever we are going to predict the ovarian response, whether it may be either excessive ovarian response or a low ovarian response, it should be accurate to our prediction. It should be reliable, and also it should be stable. That is, any part of the cycle, whenever we measure it, it should be similar across all phases of the menstrual cycle. So how does these ovarian reserve biomarkers impact on our clinical IVF practice? Firstly, the ovarian reserve markers helps us to classify our patients. We can classify our patients into a low responder, a normal responder, and also hyper responder. And accordingly, it also helps us to predict the ovarian responsiveness to the gonadotropins. Second main important thing is we can individualize our stimulation protocols. So according to by predicting their ovarian response, we can also tailor our doses of FSH according to the groups of the patients. So third one is prevention of cycle cancellation. So by knowing to which group the patient is going into, whether it is a lower responder, a normal responder, or a hypo responder, and by selecting the right dose of FSH, we can avoid cycle cancellation, and also we can avoid severe OHSS. And last one is it should have a prediction. It should also give us an insight into prediction of pregnancy. So this is a study which was conducted by Antonio Lamarca in the use of ovarian reserve markers in IVF practice. So he has done this study to predict he has done this study to show why the prediction of ovarian response in IVF practice before starting an IVF cycle is important. So by predicting the ovarian response before, we can prevent the risk of OHSS. We can individualize our therapy. We can individualize our protocols, and by individualizing our therapy and also decreasing the OHSS response, we can improve the clinical performance of that cycle. And next, the most important thing is we can reduce the patient dropout and make the treatment more cost effective. So reducing the patient dropout and making the treatment more cost effective depends upon the prior assessment of the patient by taking the ovarian reserve into consideration. The most important thing while to measure the ovarian reserve is to counsel the patient. We can counsel the patient regarding the prediction of their ovarian reserve and also their prognosis as to how they are going to perform in their cycle, whether they will be a low responder or whether they will be a high responder. If there is a high response, we can counsel them regarding the OHSS. If it is a low responder, we can counsel them accordingly. So there is an increase in the proportion of pregnancies. by taking into account the ovarian reserve biomarkers and standardizing a protocol or individualizing our treatment regimens, we can increase the proportion of pregnancies. So we can properly inform the patients regarding their prognosis, like how they are going to respond in their cycle, and ultimately this avoids the patient discomfort. So ovarian reserve markers, the hormonal biomarkers are FSH, inhibin B, and AMH. Functional markers are AFC, and genetic biomarkers are single nucleotide polymorphisms for FSH receptors, LH, and also LH receptors. So first was the basal FSH, which was first reported to be associated with the ovarian response. It was reported as a remarkably useful observation, and it became a gold standard for measuring the ovarian reserve back in 1980s. But what are the drawbacks was that it cannot predict a hyper response. So FSH is not stable throughout the cycle. It varies according to the phase of the cycle. So it cannot predict a hyper response. Inconvenience of timing the sample. So we don't know when to collect the FSH sample, and concomitant estradiol measurement should be done, because as the FSH increases, there is an, as the follicles increase in size, there is an increased secretion of estradiol, which has a negative feedback effect, and there is a decrease in the FSH seen again. So there is more of intercycle variability. So basal FSH, which was considered as an ovarian reserve marker earlier, is not considered nowadays. FSH, E2, and inhibin mutually are connected by a negative feedback mechanism, so they do not have a stable value. So they cannot be taken as ovarian reserve markers nowadays. So their circulating levels are only an indirect reflection of antral follicle count. So AMH levels strongly correlate with the antral follicle count, and antral follicle count is proportionally related to the primordial follicle pool. So because of this, there is an increased trend towards standardization of the ovarian reserve biomarkers like AMH and also AFC. So AMH and AFC, they reflect the number of growing follicles in the female ovary. They are the preferred methods nowadays for predicting the ovarian reserve with a varied degree of precision. Both AMH and also AFC, they provide good prediction of poor and excessive response. Antral follicle count is quick, it is non-invasive, but most of the times it is subjective with inter-operator variation. AMH is objective, but most of the times it lacks international standardization. So antral follicle count, how do we measure the antral follicle count? The patient is usually seen on day 2 or day 3 of the cycle. So the antral follicle count measurements requires a 2-dimensional imaging, which is adequate, and using a vaginal transducer of 7 megahertz, we usually measure the antral follicles. Use a systematic process for counting the antral follicles. Firstly, identify the ovary and decide on the direction of the sweep to measure the antral follicle count. Measure the largest follicle in 2 dimensions. Whenever you point out to an ovary, measure the largest follicle in 2 dimensions. If the largest follicle is less than 10 mm in diameter, start to count from the outer margin and sweep to the opposite margin. So you should consider every follicle which is there inside, and also repeat the procedure in the contralateral ovary. So combine the number of follicles to get the antral follicle count. If the largest follicle is greater than 10 mm in diameter, so first what you do is take the size of the follicles which are less than 10 mm in diameter, and then also count the follicles which are more than 10 mm in diameter, and then subtract the number of follicles greater than 10 mm in diameter to get the antral follicle count. So antral follicle counts we usually take between 2 to 10 mm in diameter. So we have, assessing the antral follicle count, we have some advantages and also the disadvantages. So what are the advantages is it has a good predictive value for the number of oocytes retrieved and stimulation response. It may help us to guide a protocol and other treatment decisions. It is easy to perform and personalize. It is fairly non-invasive, and it usually provides immediate results. But what are the disadvantages is that it should be carried out at the beginning of the cycle, because there is an intra-cycle variation, because as the cycle advances, there is an increase in the size of the follicles. Intercenter variation is also there because it is very subjective. One person may see 2 antral follicles, one person may determine 3 or 4 antral follicles, because it is a very subjective variation is there. It may be overestimated owing to inclusion of the atretic follicles. So the antral follicle counts, they should be taken between 2 to 10, between follicles which are between 2 to 10 mm in diameter, inappropriate for many juvenile and adolescent individuals. And also there may be intercycle variation whenever we are seeing an overweight or obese woman. So it requires the cost of ultrasound technician and availability of ultrasound machine. So, but nowadays, because of this advent of the 3D ultrasound, we are able to decrease this inter-observer variation mostly. So, is it the AMH the way forward? The AMH is produced by the primary, the granulosa cells of the preantral and also the small antral follicles. And because it is produced by these follicles, it is independent of any hormonal regulation. It is independent of FSH. So AMH as such, it has many advantages. Or AMH is AMH is measured in many conditions other than IVF. So why are we taking AMH as the most reliable marker, ovarian reserve marker? Is it can be measured at any day of the menstrual cycle. So here we can see from this study, we can see the measurements across the follicular, ovulatory period, and also the luteal phase. So the estradiol and also the progesterone levels, they are usually fluctuating. There is an increase in the estradiol and then fall in the estradiol level. In the luteal phase, there is an increase in the progesterone level. But AMH, it usually remains constant throughout the cycle. There is a little drop during the ovulation period. Then it rises and it remains almost constant throughout the cycle. So it can be measured at any day of the menstrual cycle. There is not much of variation in the AMH levels. And the second picture here, you can see the AMH level is constant throughout all the age groups. Whenever we take age group less than 20, so the AMH level is constant throughout the cycle. Though there is a decrease in the AMH seen with increasing age, but the AMH level is constant in that age also when we take it in any day of the menstrual cycle. So AMH is a very stable marker across different cycles. Here they have observed the AMH values across 4 different cycles, and they have observed that it is a very stable marker across even 4 consecutive cycles. So the stability of AMH is higher when compared to AFC. This is a study conducted by Polizos et al., where they have observed that AMH and AFC, both they have an excellent predictive ability for predicting the low and also the excessive ovarian responses. So they have shown that here they have taken a cutoff value of, for the low response, the AMH cutoff value is 1.37 nanograms per ml, where they have shown that the sensitivity is 74% and the specificity is 77%. For the AFC also, whenever we take cutoff of 8, the sensitivity and specificity are also higher. When there is an excessive ovarian response, they have taken 3.5 as the cutoff for the excessive ovarian response, and the sensitivity and specificity are higher, around 89 and 83%. For the AFC also, they have taken 16 as the cutoff point, where the sensitivity and specificity for AFC are also higher. Though AMH and also AFC, they have a good predictability for predicting a low and also excessive ovarian response, AMH is more stable than AFC. So for measurement of AMH, we had many manual assays which were available previously. There were 4 manual assays which were available previously. So, but there was more inter-lab variations between these assays till the advent of these automated assays. So the Roche assay, that is Alexis AMH, and also the Beckman-Coulter. So these automated assays, they have a less incubation time. They have a less incubation time, and also the measurement range. They have a less inter-lab variability, and also they measure as low as 0.01 nanograms per ml. So are these new automated AMH assays different? Yes, they are different from the manual assays because they have or less incubation time. And also these new automated assays, they measure the AMH levels which are less than 20% lower. That is, they can measure as low as 0.01 nanograms per ml. So Nelson et al. Has conducted a study where they have looked into a comparison of anti-Mullerian hormone levels and also the antral follicle counts as a predictor of ovarian response. Here they have done the study in 2 individual centers. In center 1, they have given a long GnRH agonist trial, and in the other center, they have given a GnRH antagonist trial. So whether it is an agonist trial or an antagonist trial, here you can see the correlation coefficient of AFC is of AMH is more than the correlation coefficient of AFC here. The triangles are AFC and also the circles are AMH. So what we can infer here is AMH has a more predictive value in predicting the ovarian response than that of the AFC. In the agonist trial and also in the antagonist trial also, the AMH has a more predictive value for predicting the Okay, so the GnRH and in the GnRH antagonist trial also, they have seen that the correlation coefficient of AMH. Sorry, I didn't get this. Requesting remote control of your screen. Hello? Okay. In the GnRH antagonist trial, also they have shown that the correlation coefficient of AMH is also higher than that of AFC. That is the predictive ability of AMH in predicting the low or higher ovarian response is better when compared to AFC. But which is the gold standard? Either we take the AMH or the AFC. So when in this study, when we compare the ovarian reserve markers when compared with age, so here we can see the area under the curve, which we can see is for the age, there is a lower predictive value when we see, but when age is combined with FSH, AFC, and also AMH, the predictive values usually change. When age is combined with FSH, the predictive value is low because FSH has a FSH is not stable, and also it has an intercycle variability. And age, when it compared, so age, when we take age with AFC, the predictive value is a little higher, and age with AMH also the predictive value is a little higher. So in conclusion, we can say that by taking the AMH and also the AFC, we can predict the response of the patient very clearly, whether it is an excessive response or a low response. But when we take a low response here, by taking the age of the patient and also by combining other ovarian reserve markers, age plus FSH, age plus AFC, age plus AMH, we can see the predictive value of all these remains almost the same. So what is more reliable in taking selecting the patients with low ovarian response is we need to take into consideration the age of the patient, the AFC, the AMH, and also the FSH of the patient to predict their response. So can ovarian reserve markers predict pregnancy? So here we can see that the ovarian reserve markers, the curve here is almost runs parallel. So we can see that the ovarian reserve markers are not beneficial in predicting the pregnancy. So why are we talking? So they are not more reliable in predicting the pregnancy, but they are more reliable in predicting only the response to ovarian stimulation. So summarizing AMH, it is a good predictive value for the number of oocytes retrieved and stimulation response. It may help guide protocol and other treatment decisions. Well characterized across adolescent and reproductive ages. It can be performed at any point during a cycle. It has a good intercycle consistency. Good inter-operator and inter-center consistency is also there, and relatively a low cost depending upon the specific AMH assay. What are the disadvantages? Is labor intensive, requiring several hours, but this has been overtaken by the fully automated assays which have come now. And it requires careful sample preparation and storage, and there is no standardization across the assays. So why do we use ovarian reserve markers? Why are we using them if we can't predict the pregnancy? So ovarian reserve markers are used only to individualize our treatment protocols. We want to individualize our treatment protocols and achieve the best outcomes by avoiding the extremes of ovarian response, that is by avoiding OHSs in hyperresponders, and also giving a maximal output rates in a normal responders, and by reducing the cancellation rates in poor responders. So we are moving more towards an individualized controlled ovarian stimulation where one size does not fit all. So based on the ovarian reserve markers, we can select the type of analog. Either we want to go for a GnRH antagonist protocol or an agonist protocol. And most importantly, we can select the dosage of gonadotropins. So by selecting the dosage of gonadotropins, we are able to avoid OHSs, and also we are able to avoid cyclic cancellations. So the ovarian stimulation can be patient friendly, it can be safe, it can be effective, it can be cost effective when we take into consideration the ovarian reserve biomarkers in the workup of the patient before starting an IVF program. So this is a study conducted by Nelson, where they have done the study in 2 centers, and they have taken the dose according to the level of AMH. Whenever there is a decreased level of AMH less than 1, so in center 1 they have taken 375 IU and they have used an antagonist protocol, but in center 2 they have used a modified natural cycle with an antagonist protocol. 1 to less than 5 they have taken 375 IU, but most of the times here nowadays we are considering only 300 IU as the cutoff which we can take. So 5 to less than 15 they have taken 225, and more than 15 they have used only 150 IU of recombinant FSH. So what did they infer is, when they have used an antagonist cycle with 150 IU of recombinant FSH, they have good number of oocytes which they have yielded. And here important thing is to show that they had no hyperstimulation syndrome. So with 150 IU, they are able to go through the cycle and they have no hyperstimulation syndrome. And also the clinical pregnancy rates, that is the first by fresh embryo transfers, the clinical pregnancy rates were also higher, even though they had a high AMH of 15 picomoles. So here we can see here what is the advantage of using an anti-Mullerian hormone tailored stimulation protocol versus the conventional protocol. So the importance or the advantages of this AMH tailored protocol is the woman who had embryo transfer has also increased in this study. And there was a less cycle cancellations, there were less hospital admissions, and also the failed fertilization was also less. The pregnancy per cycle started was also more, and live births per cycle started were also more when the stimulation regimen was tailored by using AMH versus the conventional protocol. This is a trial, the ESTHER trial, which was conducted, evidence-based stimulation trial with human recombinant FSH in Europe and also rest of the world. So they have taken approximately 1,400 women were randomized. In this trial, they have compared new human recombinant FSH with individualized dosing based on AMH levels versus a fixed dose of folitropin alpha of 150 international units. So what they have observed here is by individualized dosing using AMH and also by the fixed dose, so there was no change in the number of oocytes or live birth rates or OHSs. But what they have observed is we can take more preventive measures for reducing OHSs. That is, by individualizing our dose depending upon the AMH, we can prevent OHSs. So this is, all of us know, this is an Optimist trial which was which was taking AFC into consideration and also giving the dose of FSH where to be started depending upon the dose of AFC. When the AFC is between 0 to 7 and also 8 to 10, these people have used 450 and also 225. When the AFC is between 11 to 15, they have categorized them into a normal responder. AFC between 16 to 40, they have categorized into a hyper responder. So in a hyper-responder patients, they have used 150 IU of FSH, and in a normal responder, here they have used 150 IU, but this trial is no longer what we use. But they have shown that they can be categorized into a poor responder, normal responder, and also hypo-responder depending upon their ovarian reserve markers. So this is a nice study where they have compared the AMH and also AFC values, and also they have determined the starting dose of FSH. So here they have taken AMH as less than 0.7 and AFC less than 6. They have taken the starting dose of FSH as 375. And when the AMH value is between 0.7 to 2.1, and AFC value is between 6 to 15, 225 would be the starting dose. When the AMH value is more than 2.1 and AFC value is more than 15, starting dose would be 150 international units. So we have many nomograms or the dosograms which have come up taking into account the age of the patient, the antral follicle count to determine the FSH starting dose. So Antonio Lamarca and also Seish Kamal Sankara has proposed a dosogram in which we can take the age of the patient and also the AFC of the patient and determine the FSH starting dose. Similarly, the age and AMH of the patient can be taken into consideration to determine the starting dose of FSH. So accordingly, we have categorized our patients depending upon the AMH and AFC into a hyper responder. When the AMH is more than 3.5 nanograms per ml, we consider them as hyper responders. In this, the main objective is to minimize the OHSS risk. How do we minimize the OHSS risk? Is by using a GnRH antagonist protocol, preferably starting with a low dose of 150 IU of recombinant FSH. And if the patient is going in for the OHSS, freeze-all policy can be adopted. In normal responders, the main objective, when the AMH is between 1.3 to 3.5, they are considered to be a normal responders, and the main objective here is to optimize our success rates, that is to maximize the success rate. So by using the standard treatment, we can either use a GnRH agonist protocol or an antagonist protocol. So the starting dose of recombinant FSH in these patients would be 225 IU. In an expected poor response patients, that is when the AMH is very less than 1.3 or between 0 to 1. So these people are the low response patients or the expected poor response patients. So here the main objective is to avoid cycle cancellation and also minimize the treatment burden. So here we have the more talked about thing called the Poseidon criteria, where they have categorized the patients into 4 groups. And when the patient is more than 35 years of age and when she has a very poor ovarian response, then we can give her a duostim. Or in Poseidon groups 1 and 2, where there is a suboptimal response which is observed, you can start with an FSH dose of 300 IU and add LH to these patients to give more optimal results for these patients. So to conclude, controlled ovarian stimulation entails prediction, counseling, and individualization. Ovarian reserve markers are useful to predict the ovarian response. AMH and AFC are the methods for predicting the ovarian reserve with a varied degree of precision. They are not useful for prediction of pregnancy outcomes. Female age alone is the best predictor for pregnancy because it is correlated with blastocyst euploidy rate and also with the ovarian reserve. So up to now, no ovarian reserve marker is able to predict oocyte quality. Only the age and also the quality of the eggs are able to predict the oocyte quality. Thank you.
Ma'am, thank you so much, ma'am, for a wonderful lecture as always. I think you were very precise and elaborate at the same time with a lot of scientific evidences. So we can open up the Q&A for discussion. Doctors, you can type in the questions in the chat box. Ma'am, there's one question already, ma'am, from Dr. Maithili. And she asks, if you have a 30-year-old lady with an AMH of 1.29, will she conceive naturally, ma'am?
30-year-old lady with an AMH of?
1.29, will she conceive naturally?
Yes, if her husband's sperm count and all are good, 30-year-old with 1.2 AMH, she can conceive naturally.
So before Dr. Kiran goes with the next question, Dr. Sweta ma'am, I am
Yes.
Kumar. I work with Dr. Kiran. Privately, Dr. Patiola Reddy has messaged me privately. Therefore, Dr. Kiran will not be able to see the comment.
Oh yeah, tell
So
me.
Dr. Reddy says missed the initial part due to connectivity issues. At the outset, I would like to congratulate and thank Shield for this wonderful initiative. Request for a small favor. If you could share the link of this recorded webinar and the links of recorded webinar conducted by Shield, etc. So before we could take any step, first we must take your permission, ma'am.
Oh yeah, sure. You can share the slides with her.
Okay. Thank you, Dr. Sweta.
Yeah.
Thank you, sir.
Dr. Kiran.
Yes, sir. Thank you, sir. Ma'am, the next question is from Dr. Nalini. If you have low AMH and recurrent pregnancy loss, what is the next step, ma'am? What do we do?
There is a low AMH and recurrent pregnancy loss. Probably with a low AMH, we should check her oocyte quality. How is her oocyte quality? And also the age of the patient is also more important here. If she is of if her age is a little on the higher side, then maybe we can do a PGS and see whether the oocytes are euploid, more number of euploid blastocysts. If you transfer, we can decrease the pregnancy loss.
Thank you, ma'am. Ma'am, I had a question, ma'am. Nowadays, we hear a lot about this FORT or follicular output rate, which basically looks at the proportion of follicles, their response to the FSH, ma'am. What are your thoughts on that, ma'am?
Yes, this FORT is the follicle output rate, which we usually see. This is what is, see, you have a patient who is having a normal AMH, a normal AFC, and you have other patient who is also having more or less the same AMH and also AFC. If we give same dose to these two patients, that is, we start with an FSH of 225 for these two patients, they respond differently. The first patient think if the follicle output rate, it should be more than 50%. That is, if the AFC is around 10, so around 6 or 7 follicles or 8 follicles should come up to be a dominant follicles. Okay. If the FORT is less than 50%, then we say that the patient is having a suboptimal response.
Thank you, ma'am. Ma'am, the next question is from Dr. Pushpalata. We have a female who's aged around 26 and her AMH is 0.7 and with regular cycles. Can she try IUI or to speed up for IVF? What should be the approach, ma'am?
Yeah, I would say you would speed up for IVF for this patient because the AMH is already on the lower side, and also check on the antral follicle count of this patient also. If AMH and AFC are correlating, though the age of the female is 26, you should speed up for IVF.
Thank you, ma'am. Ma'am, I had one more question, ma'am. Nowadays, we routinely, many doctors use DHEA very commonly. And there are a lot of studies which I have come across which talk about the other pathogenesis of ovarian reserve, like increasing the blood supply, where we have L-arginine, and increasing the mitochondrial function because of coenzyme Q10. What is your comments, or what are your comments on that aspect, ma'am?
So these adjuncts, we say, whatever you're talking about, DHEA, L-arginine, all these are adjuvants which we use for to improve our success rates in IVF. So whenever we do have a patients with a low ovarian reserve, we usually give them a DHEA for 3 months, expecting them to have a little improvement in their oocyte quality. So this is usually given 75 milligrams. We usually give daily for 3 months. But there are no studies that prove that giving DHEA will definitely improve their AMH or definitely improve their oocyte quality. Giving L-arginine is different. So that usually increases the blood flow to the uterus. So wherein, wherein we give in patients with, whenever we have a recurrent implantation failure, and in such patients, there are little thrombus which are seen in the spiral arteries. So these may hinder the blood supply to the uterus and will not allow the blastocyst to get implanted. So in such cases, we usually start them with L-arginine so that there is a vasodilator. So they will increase the blood flow to the uterus and create an environment in which the blastocyst can implant.
Thank you, ma'am. Ma'am, the next question is from Dr. Indira. What is the level of AMH where we directly go for IVF? Is there any particular level of AMH?
I would suggest if the level of AMH is less than 0.7, then we can go for IVF.
Thank you, ma'am. Ma'am, the next question is from Dr. Shilpa. We have a female who's aged about 34 years with AMH of 0.4 and her AFC is 5, ma'am. The husband semen is normal. So Dr. Shilpa wants to know, in this situation, should we do 1 or 2 cycles of IUI before IVF?
This is very tricky, when the patient is 34 years and you have this situation. See, you can stimulate the patient for 1 or 2 cycles of IUI using gonadotropins. You can use combine ovulation, oral ovulations with gonadotropins and see how her response is. Only 1 or 2 cycles of IUI. If she conceives, it's well and good, but if not, you can shift for IVF.
Thank you, ma'am. Any more questions to ma'am, doctors? Okay, ma'am. There's another question from Dr. Shilpa, ma'am. She's asked, she wants to know whether giving growth hormone for low AMH is justified.
Yeah, we can give growth hormone for these patients, but giving growth hormone may be a little cumbersome, and also it may be a little expensive for these patients. But if you're going for IVF along with growth hormone, then that would be a good option rather than giving it in an IUI cycle. You can give it in an IVF cycle.
Dr. Shilpa also wants to know, ma'am, what is the dose and when to give?
Growth hormone?
Yes, ma'am.
Growth hormone is usually started from maybe day 1 or day 2 of the IVF. Along with, you can give it daily, but it is very giving the dose is also very tricky, and also the cost of the patient will also go high giving the growth hormone. And also we don't have many studies which show that growth hormone will definitely give us good results.
Ma'am, the next question is from Dr. Priyamvada. What else can be given for low AMH apart from the things you mentioned, ma'am?
For low AMH, we can try DHEA for patients. Usually with low AMH, these people are poor ovarian responders. So we can try either testosterone gel for the previous cycle before starting one with IVF. We can use DHEA. We can, if it is a poor responder, we can start with a 300 IU of recombinant FSH and add on LH for these patients. So all these options are there.
Thank you, ma'am. Ma'am, the next question is from Dr. Pushpalata. She wants to know, is it mandatory to do AMH in infertility investigations for patients?
See, if you're doing scans by yourself and you're looking at the antral follicle count, if you think that the AFC is good for the patients who are younger patients, maybe less than 35 years of age or less than 32 years of age, if the AFC is good, there is no need to do an AMH. But when the patient age is more than 32 years or more than 35 years, doing AMH would definitely give you a little insight into the patient's profile.
Any more questions to ma'am, doctors? So there are a lot of requests for the recording of this webinar, ma'am. So with your permission, we will send it to the doctors.
Yeah, sure.
Yes, ma'am. The next question is from Dr. Daisy. What is the normal value of AMH which is safe for
AMH safe for IUI?
Yes, ma'am.
For IUI, usually we take it 1.3 to 3.5 would be an ideal value for IUI. More than 3.5, the patient would be would have a hyper response. So you need to see that.
Dr. Kiran, Dr. Anuradha Vasishti Sethi had raised her hand.
Yes, sir. One minute. Dr. Anuradha, ma'am, can you unmute yourself? I have unmuted you. Chitrakala. Dr. Anuradha, can you just unmute her?
Dr. Anuradha Vasishti Sethi.
Ma'am wants to say something.
So I have a question. Can I ask?
Yes,
Yeah,
ma'am. Please.
Dr. Anuradha.
So I am from Delhi. So I have a question that I have a patient of 33 years of age, and
Okay.
she's grade 3 endometriosis.
Mm-hmm.
And in one ovary, I can count this AFC very well. But in the other one, because of large endometriotic cyst, I'm not able to count the number of antral follicles. And AMH comes around 1.2.
Okay.
So do you think because of endometriosis, AMH can be a little bit haywire? And sometimes when I'm doing this induction, even with recombinant, I'm not able to, see that follicles very well in the ovary, which has got a large endometriosis, and the other side also not very good response. So do you think endometriosis in some way can be like detrimental in this AMH levels, and of course for counting of AFC?
Yes, definitely. In patients who are having endometriosis, the AMH is a little on the lower side. See, in the ovary where you are having that endometriotic cyst or the chocolate cyst, it is very difficult for the normal follicles to come up. So one thing, whenever you're using doses of, whenever you use recombinant FSH or HMG, it is very difficult for those follicles to come up. So, and the other ovary maybe, with the other ovary, maybe you can be getting the follicles. So, but if it is very disturbing, the endometriotic cyst or the chocolate cyst is increased more in size, then you can excise the cyst and then go with your infertility management.
Okay, so I know one more question, though it is not directly related to AMH and AFC, but do you think large endometriotic cysts can sometimes take over this tubal endometrial kind of relationship, and could be a major reason for not to, fertilize and all?
See here, the thing is, one thing is like they will not allow the follicles to grow. And second thing is that maybe because it is a very huge cyst, maybe a little that endometrial relationship, the tubo-ovarian relationship is a little disturbed in endometriosis because she is grade 3. So maybe because of that also she must have a problem.
Yes. All right. Thank you so much, ma'am.
Thank you.
Thank you so much, Dr. Anuradha. Ma'am, the next question from Dr. Karthik Savalia. When we are looking at AFC for ovarian response, and AFC of 15 is the cutoff for one ovary, or both the ovaries are hyper-responsive?
When we are looking at AFC for ovarian response, AFC of 15 is the cutoff for one ovary or both the ovaries. It is for both the ovaries, not for one ovary.
Any more questions to ma'am, doctors? Ma'am, Dr. Karthik and Dr. Daisy, they thank you for answering their questions, ma'am. So, ma'am, probably we can wind up. Thank you so much on behalf of Shield Healthcare and the audience. It
Once
was a
again,
great,
I thank Shield for this webinar, and Dr. Kiran, thank you a lot for this.
So I would like to thank the audience also for logging in at these times. And as we know, ma'am prepares a lot with a lot of scientific depth with the articles, as well as making it very clear and practical for us. So thank you so much, ma'am. Wishing to have a lot of many more webinars in the future.
Pleasure. Yeah.
Thank you, Dr. Sweta, ma'am. Thank you, audience.
Thank you so much.